Oh, not a Chromebook. Huh. Interesting. It recognized the decimator. That's neat. Okay, so screen extend display. If that's the case, then. But you need your notes.
I mean, I don't have to have them.
Are you sure?
I kind of ran through it last night.
I know you probably prefer them. I just want to make sure. Because, see, if we're extending, then that should mean that technically somewhere, yes, it will throw it out there. But I need if I'm going to do it that way, I need the notes thing, because you'll be shooting in the dark here in a second. Where are your notes? I hate using Google. I thought I presented. And then what I should be able to
So
do.
you're just gonna drag that over? Is that what you do?
That way you'll still have notes while you go through this. But the thing is, I can't see unless I throw you up there already. And I don't want to.
You can throw it up there. I don't care.
Okay. If that's the case, you should be able to. Let me throw it up there, and you should be able to drag it over.
Drag it over. Okay.
I guess they can see a little bit of the magic.
All right. Let's. Is it over? Alright, so so do I need to just hit the I'll let you do it.
If it'll give it to you, yeah. Should give it to you. Might not give it to you. Voila. And now you got your controls there.
Okay. Good morning and welcome to the Saturday morning session of our annual clinical assembly here for the AOCO HNS. We'll begin this morning's session with 2 hours of retina work. We're so glad that you're here, and I express my gratitude to Dr. Wayne Davis from Missouri Retina Associates in Missouri, who will be presenting our first lecture.
All right. Well, thank you all for being here so early in the morning. I'd like to thank the committee for giving me this opportunity and for having a mall next to the building, because when I got here and realized I forgot to bring my clothes, I had a little panic a moment, but they hooked me up at the mall. So they told me that I could speak on anything I wanted to, and so there's a lot of things in retina I could touch on. And something that comes up very often in my practice is texts where people say, hey, here's this OCT I got, what is it? I get it from all across the country, so I thought I would put this together. Another reason I did this is because I get a lot of referrals for things that aren't completely accurate, and so I think pointing out a few things to help out with our differential and maybe formulating a plan on what to do with these patients that show up with some weird findings. So we're going to start off, disclosure, I don't have any financial interest, although if anybody's a retina specialist and they're looking to practice in mid-Missouri, please call me. All right, so I kind of went over our objectives a little bit. I know there's a variety of people in here with different backgrounds and different training and education. So we're going to start off a little basic. I love this picture. Obviously, I stole it. Hopefully, that's enough credit for the people that made it. But this is a great picture because it shows, and this is available online too. You can just Google Heidelberg OCT or something, but it shows a normal OCT, every layer is highlighted, it blows up a big piece, color coats it, and I think it's important, I'm going to run through this really quick, but most things with the eye, you think about lights coming in, it hits the cornea, goes through the pupil, goes through the lens, and I kind of go through this model with my patients while I'm describing everything I see. But with the retina, it's kind of backwards because light goes right through the retina and it starts down here. So it hits that RPE layer, and then it makes its way back up to the signal to go to the brain. And so if we're thinking of the retina that way, it helps us with our differential and come up with what's happening, why it's happening, and what you can do about it. I was going to go over every layer, but last night I ran through this to make sure I had an hour of material, and I put my wife to sleep, and I went over, so I'm not going to do that. But in my practice, and probably most people, I kind of cut the retina in half. You've got your inner and your outer layer. Most pathology is sort of divided that way. And so it's good to know maybe which layer exactly it's in, but if you just cut it in half, makes it a little bit easier. Okay. And let's go forward. So I'm going to so this will be a little bit different than presentations I've seen before. I'm not going to have a lot of writing. I'm a very, very visual person, so we're going to just use a lot of pictures, and we're going to walk through some things. The first four things I have up here, I think four, are just some basic, this person walked in, here's the OCT, what's going on. Hopefully some of them are pretty easy, but hopefully some of them you might scratch your head a little bit. I just mentioned I kind of divide the retina in half, so if we're looking at this, Dr. Davis, is it the inner or the outer retina that's being affected here? Well, you can't really see it. You've got this big ball thing blocking our view. It's got a shadow effect, but there are a few clues. If you're just looking at the horizontal view there, you're not going to get a lot. If you go to the vertical view, you can start seeing there's a little internal limiting membrane, a bunch of stuff, and then the retina actually looks pretty good there. And this is a great tool a lot of people don't look at, but that little black and white picture up there kind of gives you some hints there, right? So there's this kind of layering, almost like a boat going down, right? Darkness. It's pretty obvious when you look at the patient what they have. So they've got this pre-retinal hemorrhage, and right up here in the arcade, there's this kind of fibrotic looking thing there. Well, this was an aneurysm, a macroaneurysm that burst. It started fibrosing. And you've got some blood, and it's actually in multiple layers. So here we're pre-retinal, right? We saw that in the OCT. It's all in front of the retina. Over here, you've got some blood underneath the retina, and there's very few things that put blood in every layer. And so that makes it kind of nice. But this one should be kind of obvious. If you do an angiogram on this, which, I don't have the angiogram, but you can actually see the aneurysm. Sometimes you can see them pulsating as you're watching the video. It's kind of neat. So then we go on to this case. This one's a little more subtle. If you look at the horizontal view, all the layers look like they're pretty intact. If you look over at the vertical, this looks pretty normal. You come here and there's this kind of whitish look on the OCT, okay? Now, whitish look means something's going on that's not supposed to be there, right? If you look over at our cheap picture, you can see some things. There's a little white thing right there. There's a little white thing right there. And those are in the vessels. So this person's got some emboli inside those arterioles. When you have an acute occlusion, you don't get cystoid spaces, but you do get retinal thickening. There's a difference between intracellular swelling and extracellular swelling, right? So with like a vein occlusion, you get those cystic spaces. That's extracellular swelling, pockets of fluid in between the cells. Intracellular swelling, the tissue just thickens up. You don't get those cystoid-like spaces. So this was a little vein occlusion. I have an angiogram here. So you've got your arteries are usually arteries are usually skinnier than the veins, which are usually a little bit fatter. Oh, good, so this, hopefully your view's a little better, but it's nice on my computer. This is an early with the arteries filling up, and you'll notice there's some arteries missing in here. Later on, they fill up, but you've got some irritated tissue because there's a little swelling there. And you do have some I pointed out those emboli. They're kind of hard to see on this picture. It's kind of washed out, but Here is another OCT. This one's a little more obvious, and I put this as the next one because it's the same pathology. It just stands out at you more. Occasionally, you've got to really look through the OCT and not just kind of blink at it. So this one, you've got that nice intracellular thickening where it's got that hyper-reflective activity. Vertically, it's a lot more apparent. This patient ended up having Wegener's granulomatosis. It's an occlusive vasculitis disease. So they kept coming in with more and more emboli. You can see their angiogram. You've got just all the arteries are kind of lighting up. Looks like the venule there is lighting up too. Once we figured out what was doing it, it's pretty treatable. Unfortunately, it's long-term treatment. But so this is that same patient. Again, this is early. Now with that intracellular swelling, the cells have died, so all the pumps along the membrane of each cell are not working, and that's why fluid is just brought in. You get thickening. Well, once the cell's been dead for a while, it atrophies, right? So a chronic appearance after a retinal artery occlusion is loss of those inner layers. So you can see the outer layers are still there, the inner ones are just thinned out, and we'll come back to that a little bit later in my lecture. All right, so this is another one where you've got kind of that, almost looks like the intracellular thickening, right? You've got an increased signal in the tissue. It's a little thickened up. This one, though, there's sort of a shadow effect. And if you look at the vertical cut, we do have some cystic spaces, okay? So with this one, do an angiogram, there's a lot of blockage because there's a lot hemorrhaging, and then along the vessels, you can see there's quite a bit of leakage here. And if you look close, again, it shows up pretty good on my screen, but there's these little telangiectatic vascular changes kind of within and along the edges of the lesion. Those telangiectatic vessels are, along with this picture, very common with, hopefully you all know, a branch vein occlusion. Okay. Another hint here is if you look at all the vessels where the arteries cross over the veins, it kind of has this little pinching effect that you can see. Another clue. So then this OCT, I mentioned you cut the retina in half. You've got your inner and your outer. You might think, well, Dr. Davis, this is kind of in between the layers. There's this weird kind of increased activity in there. Now, another clue again, I mentioned it's kind of nice to kind of glance up here. You can see these vessels go all over the place. It's a very abnormal vascular architecture there in that retinal tissue. Now, I recently had, I guess I should have started my talk with this. A lot of people say, oh, it must be kind of boring being a retina specialist. You're just doing injections all day. So where these slides came from, this was just a day in my practice. I just grabbed every patient and kind of put it together. So my partner recently retired, and so I'm inheriting his patients, and this was one of them. So I went back a few years, and this patient had an older OCT. We have a different machine now, obviously. But the patient was diagnosed with a Valsalva retinopathy. Kind of interesting. And he had an old picture, as you can kind of see the little hemorrhage there, right near the fovea. And then he had an old angiogram. And what's interesting about this is you can see all these weird vessels, almost like anastomosis, kind of everywhere. So that OCT you saw, I think I put it, I didn't. Let me go back. There we go. So sometimes you'll catch a little weird vessel in the retina running through it, and it's going to show up like some kind of an occlusive type thing, but it's just their normal vessel. They were just born weird. Okay. All right. So we're going to, I think I just have a couple more of these, and then we'll get to more specific stuff. So with this one, you can see definitely the outer retina's changed. You got these little hyperreflective spots in the retina, for lack of better words. And unfortunately, this isn't showing up. You could almost argue there's a little pocket of subretinal fluid right there, and this doesn't show up, but there's a couple little cystic spaces. So you've got stuff in the inner retina, the outer retina. What I want to point out with this is anytime you have an elevation of the RPE with a little fluid either under the retina or a little cystic space, that's really a CNV until proven otherwise. Okay. Do an angiogram on this patient, and you can see pretty early there starts to be a little bit of a leakage, and then you can really see that choroidal neovascular membrane kind of blossoming there. So, all right, so now we're going to go on to different topics, because with the different layers of the retina, you get different pathologies. And one of the most common is you get a little subretinal fluid, and there's different manifestations of it, and there's several different things that can cause it. So here's a few. Those are all different etiologies, but they can look kind of similar. So we'll start off with this one. You got your foveal depression there. If you look at these photoreceptor segments, they're not happy. They're swollen, they're enlarged. Looks like some of them are starting to slough away. If you look to either side of the subretinal fluid, well, if you look to the left, it's pretty normal. If you look to the right, there's a little disruption in there. You do have these little, call them drusenoid changes. I don't know if there's a better term, but you got those little deposits there. And hopefully you're running through a differential in your head. When people send me a picture like this, I'd say it's probably this, and I'm probably right, but really you need to get an angiogram to see what's going on. So if you get an angiogram here, we like to compare, most of the angiograms I'm going to have up here, we're going to have the early picture to the left and then a later picture to the right. And to the left, you can see there's a bunch of little bright spots, right? Some hyperfluorescent spots. To the right, after the dye's been there for a while, most of those spots look exactly the same, but you do have a little cloud that's kind of forming in here. So the ones that stay the same, that's all staining. Drusen loves to stain, so it's sucking up that dye like a sponge. So mostly drusen, but then you've got leakage in there because they do have some CNV. So what do you do about that? Most of the time we do an injection. Yeah, this was one of the ones that we injected. So this is, they got an Eylea, it all went away with one shot. Kind of a typical response which we would expect. Oops, went too quick. All right, so here's another picture. This one looks very similar. Your photoreceptor segments, they're getting a little thickened. That means it didn't happen today, right? It's been a little while because those cells are getting intracellular swelling there. This one's got another little sign here. So this is called a double layer sign. If you look at the back of the RP, it's nice and straight, and then there's a little elevation. In the retina community, I guess there's been a lot of talk about what's this double layer sign mean. A lot of times you'll see it without any subretinal fluid or CME. If you look at a lot of OCTAs and do different imaging things, and the universities are telling us these double layer signs where there's a little CNV that's kind of hiding out. So if you see a patient and you're calling it dry macular degeneration, but you get this little double layer sign down here, you probably want to watch them a little closer because that's kind of a ticking time bomb. It's going to go eventually. But this one already went, so I kind of gave away the diagnosis. But if we go forward, excuse me, this one doesn't have a whole lot of drusen in here, but you can see that little CNV network kind of growing in there. And this one, I don't think they wanted shots. Let's see my notes. So we didn't do the shots on them because that's kind of hard for some people to digest, but we did do photodynamic therapy. Sometimes it works. So we still have that as a tool in our office, and it can be effective. This person never had a recurrence, so that's kind of nice. That's not the typical story, but it does have its place. Here's another one with some subretinal fluid that looks pretty similar. Now, if you look at the outer segments here, yes, they're swollen compared to there, but they're not quite as ratty as the other ones we saw where you've got like these chunks kind of sloughing off. So maybe this one hasn't been quite as long, but it looks like about the same amount of fluid, right? So again, we do an angiogram, and this one's different. You've got a pinpoint spot of leakage that grows over time, right? So I guess I should be pointing these things out for the med students. And this has a few different treatment options. And this one we did PDT on. So I usually tell my patients we could do a little focal laser and just kind of burn it. The downsides are you're going to have a blind spot. In this location, they may not have noticed it. I've gotten a little better with my accuracy over the years. And it's a pretty small spot. So you don't usually laser the whole big spot that's been there after a while. I pull up the early picture and just get the little spot. It's very effective. Nothing's 100%, but it's pretty much 100% with this CSR stuff. But you can also do photodynamic therapy. There's medications. I should tell you, I don't mind if you stop me and ask a question if you want me to go into a little more detail. Go ahead. Urgency with that?
You know, in these subretinal, we find them as regular routine.
Yes, that's a great question.
And then we get the thing is, we'll let you know or we'll call.
Yeah, so I'm glad you asked. So if we go back to like the macular degeneration one, you know, within a week, that's fairly urgent, right? This, I usually, where did I go? This one, oh, I'm going the wrong direction, sorry. All right, so this, I actually usually make them wait a month before I even think about doing treatment. Because most of them will go away on their own. And I have another example of that. But the problem is they can look really similar. So if you're not doing angiograms in the office, I would say send them over within the next day or two. Something I tell a lot of my colleagues is, I think it's this, and I'm probably right, but first you don't want that liability, right? I have had some of the optometry community. I've had patients sent over like, yeah, we saw this. I told them, let's wait a couple months, see what happens. And then they come back and it's like totally fibrosed and I can't help them now. Just a sec, let me finish this question. So really, even if you know what it is, it's good to pass the liability on. And I don't mind doing that. If your retina folks don't like that, then they shouldn't be practicing retina, right? I feel like a big part of what I'm doing is just spreading the liability for other people so that they don't have to take it all on themselves. And I don't mind doing that. I feel like I'm pretty good at it. I make the patients think that their doctor's, you know, amazing and the best thing in the world, even if I hate them. So, and that really should be the attitude of your retina doctor. Does that answer your question? Okay, I saw a hand come up over here. Yes, it is. So when you the stress goes up, your body makes its own steroid. So for medical students here, number one thing is steroid use, and it doesn't matter if it's oral, topical, an inhaler. For asthma, people are like, no, I don't take any steroids, and they pull out all these inhalers. You're like, you take a lot of steroids, buddy. Stress, you increase your natural amount of steroid. That's why they think it happens. We don't actually know for sure why this happens, but it correlates pretty good. Caffeine use, I had a patient come in, he said he's not stressed out, he said he doesn't take any type of steroids. Nicotine, tobacco, smoking, those will do it too. He doesn't smoke at all. I was like, well, do you drink any caffeine? He's like, oh, a little bit. I have like 3 cups of coffee a day. I said, well, how many cups, how big's your cup? It was the entire pot was his cup. So he drank 3, and so he stopped that. His CSR was like huge. You couldn't even see it outside the OCT. It looked like a total Makoff retinal detachment. He stopped his coffee a month later. It was totally gone. Kind of neat. Does that answer your question? All right, go ahead. Yeah, any type of steroid, yeah. Now, I do have some patients who have like Addison's disease or something where they have to take some of these medicines the rest of their life, right? And you don't want your patient to die because they have CSR and say, stop your medicine that's keeping you alive. But those patients actually do pretty well with PDT, even if they continue with steroids. A lot of times it doesn't come back after you've treated the lesion. Now, they might have another lesion pop up, and then you have to treat that, but there's still hope for them too. So, did I see a third hand? Yeah. I think that would be good. Tech people, I think I put them to sleep. Yeah. Is there any way we could turn the lights off up here? I don't know, I might put the rest of the view to sleep if we do that, but I agree. I think it'll make the pictures a little better. All right, I'm going to keep going while they're messing with that. Am I going the right direction? Sorry. Okay, so this is the same patient. Now, they got treated with photodynamic therapy, and then they came back and they had a recurrence. And so I did another angiogram. Now it looks different, right? So you don't have a pinpoint leakage, you have a little CNV there. So something that's important to think about with these CSR patients is they can develop CNV. So you can't keep treating them and say, hey, go ahead and stop the steroid or caffeine again, go do yoga to get the stress out. Because if we had done that this time, it kind of would have permanently damaged their eye, right? So they got a couple Avastin. I guess I should... Oh, I didn't put the follow-up OCT. So they got a couple of, I think it ended up being 3 actually, Avastins. and it went away, and then it hasn't recurred, thank goodness. So, but keep that in mind with your CSR patients. Sometimes they'll convert, and their CNV can look pretty similar to what their CSR looked like. Go ahead.
How often are you getting an OCT? Is it just systematically?
No, so with these CSR patients, my typical approach is somebody comes in, we do the angiogram, you've got CSR, not something else that's weird. I say, I'll see you in a month, stop drinking caffeine, don't smoke, don't use steroids. And start doing relaxing exercises. So when they come back in a month, most of the time it's better, and then I'll see them in 3 months, 6 months, maybe another 6 months, and then a year kind of a thing, just because they usually slip back into whatever their bad habit was before. Every time they come in, I do an OCT, partly because most CSRs, and I'll show you, there's another picture in here in a minute, most CSR happens and the patient never knows it because it's outside the fovea, right? And if you're doing OCTs every time, you'll catch some of those other lesions and be like, did you slip? Are you smoking again? Or, did you have to use your inhaler a little bit more, just to kind of ingrain in them the importance of it? Because unlike most of the tissue, another thing I do to really drive it home to them is most of the body can regenerate and heal. This retina is central nervous tissue. It's actual brain tissue. It will not regrow or regenerate. And so when you show them that it's almost into the place that does 90% of their vision, it kind of like clicks. Oh, I better be better, right? Did I answer your question, or did I kind of go on a tangent there? That was good. Okay. All right, so here's another picture. And this one, we've got a PED next to some subretinal fluid. And here's a little tip. This wasn't part of my lecture, but we tried for years to bill for OCTs for patients we were following, and sometimes you don't get reimbursed because the right pathology isn't there. And we found out if you code for vitreomacular adhesion, they cover that, even if they have nothing. And so this would be like a broad-based vitreomacular adhesion. You can bill for that for your OCT. Anyways, side note. So on this, we did an angiogram. Oh, this was the one I was talking about. So you can see in the early, there's those 4 spots. And then in the late, 3 of them didn't change at all. So these are old CSR spots that were active and problematic, and they never knew about it. And you can see how far away from the fovea it is. Well, this spot popped up. It's pretty good distance away as well. But as you saw in this picture, it was leaking into the fovea, so they were symptomatic. So you can show them this and say, no, this is something that you've been dealing with for a long time, you just didn't notice. But now that's kind of a bigger spot that's active. With this patient, this was one of the ones I did nothing on, so we watched him for the month, saw what happened. And all the fluid's not quite gone. You can see there's a little crescent there, but it's pretty far away from the fovea. They feel like everything came back. You got it before I got to go back here. I don't have the black and white picture. We got it before the photoreceptors, sloughed away and died. So they were happy with this. Even though there's a little fluid, I would keep watching them. And it does eventually go away for this patient. Here's another patient with some subretinal fluid. And you can see this one looks pretty similar to the CSR. It looks kind of, is it macular degeneration? The difference here, it almost looks like they have a posterior staphyloma going on, right? If we do an angiogram, we do get this kind of stippled leakage pattern over here. It's obviously leaking in towards the fovea. The diagnosis on this one isn't super obvious unless you take a step back and you look at the big picture, and they had a nice melanoma. Now I put this in for a couple reasons. One is, take a look at the whole picture, right? The other one is I do have some nevus patients. Sometimes these nevuses will leak a lot, and you get these weird little, maybe it's CNV, maybe it's something else. Sometimes they'll respond to photodynamic therapy, sometimes injections, sometimes nothing makes them stop leaking. And this is a melanoma, but a lot of those aren't melanomas, so then what do you do? Those can be really tough cases because you don't want to put a plaque or do something weird. And sometimes people have progressive vision loss, and there's not a lot that you can do about it. Okay. Yes. Oh, sorry, I didn't see your hand.
My understanding was that if you saw drusen on the surface of the nevus, you thought it was benign.
Yes. So let me go back. So this one's been leaking a lot. There's some exudates there. There is some drusen. It's kind of hard to see the coloration because you also hear about orange pigment, causes that's melanoma if there's orange pigment. Honestly, I have a hard time seeing what's orange, what's yellow sometimes. So yes and no. It's kind of a bad answer for your question, huh? All right, sorry. If there's a hand and I don't see, just like this gentleman did, say something. All right. Here's another patient with some subretinal fluid, and if you look at it again, sorry, let me get the laser. You've got that thickening of your photoreceptors within the fluid, which means this has been kind of chronic. It looks like some of them are sloughing off. Maybe there's a little bit of drusen, maybe not. This is a little tricky one, and last night when I was going over this, I hit myself because I didn't put the angiogram in. But we've got an autofluorescence, and this is kind of a striking picture, and it's very classic for what this patient has. I don't know if anyone's got it in their mind, but coming from the fovea, you've got these radiations coming out. You got the right and the left eye up here. This patient, you have to look through their medical history to see what they have, but they were taking Elmeron for years and years, and they had been seeing another doctor that was injecting their eye every month because they thought this was macular degeneration. Elmeron toxicity, there's a lot of lawsuits going on across the country for this kind of thing, so be a little bit careful. You're not going to see the CNV on the FA, and these patients' OCTs look terrible, and the image or the picture of their retinas look terrible, but let's see if I have I don't. Sorry, I didn't put. I've been following that person for years, and their vision's been 20/30 since the day I saw them. I've never given them an injection, and their patient's vision's still 20/30, and their OCT looks exactly the same. So once you stop the Elmeron, it doesn't really progress. It doesn't get better, unfortunately. The patient hasn't really noticed any changes in their vision either, even though the vision looks even though their imaging looks bad, but they do not have CNV, so just be aware of that. All right, this was the Elmeron toxicity. So this is an OCTA of the same patient, and if you look through all the slices, no matter how deep or superficial you get, there's no abnormal vessels in the OCTA there. For those of you using OCTA, starting this year, here's another little tip. You can bill for your OCTA, and you can bill for fundus photos on the same visit if you code the OCTA. But to do that, you have to put an interpretation for the OCTA and for the OCT in order to be able to bill for both. So kind of another little financial tidbit. Did I see a hand? Go ahead.
I didn't know about the OCTA. I actually was on a test question for this academy.
Uh-huh.
And I wanted to know, how do you feel about that versus the FA? As far as
Oh, versus the FA? Good question. So if we go back and we look at this, it's spectacular. It's spectacular if you have a diabetic patient or a vein occlusion. I mean, you can see all this, capillary loss, these ischemic spots. With CNV, you can make it look like they have CNV if your person does it right, or you can make it look like they don't. So I don't think it's quite as useful for that. If you're looking for leakage and where the fluid's going, or you're trying to find CSR, this does nothing, right? It doesn't show leakage. I read a lot of studies in the journals, and sometimes they'll be like, hey, look at this OCTA where there's leakage. It's like, really? That got in a journal and it was peer reviewed? You can't see leakage with the OCTA. So any pathology where that's important, you really need an angiogram. And if I have an OCTA and it looks like I know what they have, I usually still get one angiogram. I'm not the kind of guy that does it every 3 months. I usually do it once, get the diagnosis, and then run with it. If there's something weird in the clinical course, I might repeat it again. Or if I need to do a focal laser, it's critical to get the FA because you can see aneurysms on these OCTAs, but not all aneurysms leak, and you really shouldn't use that to guide your focal laser. You really need to see where the leakage is coming from. So go ahead, Tim.
Is it
Yes. So we do the oral sometimes because you get these terrible patients that don't take care of their diabetes and they have no blood vessels that you can get. And when the dye does get there, eventually it takes a little longer, but when it gets there, it's kind of washed out a little bit. It almost makes it, when the dye first gets there, it's kind of like the washout pictures on a dye that you get in through the vein. And so interpreting that's kind of a little difficult. So in my experience, it does make a big difference. We have a phlebotomist in our practice, which we didn't hire a phlebotomist purposely, but he had lots of experience and wasn't happy with his career, and so joined us. So we very rarely don't get it. Before we had him, when my technicians, I think they had to try at least twice, and then they would come and get me, and I've never missed. I don't know why. I don't do it very often, but I go for the little vessels that they won't go for, and I use like a pediatric needle when they call me to come in, and we can usually get it somewhere on their hand or something. So, all right. Okay, so we're going to jump from subretinal fluid to cystoid macular edema. For the med students, this is called cystoid. A true cyst has an epithelial lining. None of these have that. I don't think. I might have just lied, but let's see. Oops. So these are all pictures of different etiologies, so we're going to jump into them. So this is the first one. Hopefully this is kind of an easier one. If you look at the cystic spaces, they're kind of tracking down one layer of the retina, so that's kind of a big hint. It's sort of splitting, right? So this, you might not read this in a journal, but I call that schisis-like CME in my notes. If you do an angiogram and it's truly just schisis, you don't get any leakage. So your early picture over here looks just like your late picture. For those of you in the front row, you might say, wait a minute, there's a little bit of leakage in here. Sometimes those little cystic spaces will pool. There is some dye that will get into that, so you will get a little bit of a leakage or a pooling kind of effect. But your optic nerve stays totally dark. The vessels have no leakage. There's no petaloid changes. This is just a little schisis. Another thing to point out, you don't really see it here. I probably should have not made this the first one, but with ERMs that are causing that, you get these little like striations where the membrane's kind of pulling, sort of like your bed sheet. If you crinkle it, it'll have some lines coming out. I'll show you, hopefully that'll show up in a minute on some other pictures. So here's a picture. So we didn't totally leave subretinal fluid. We've got subretinal fluid and CME. This is the right eye. If you look over at your cheat picture, you can see your optic nerves to the right, so you know it's the right eye. This one is the left eye. Got your optic nerve to the left. It's the left eye. So this is a bilateral problem. If we do our angiogram, it looks terrible. You do have that quote-unquote petaloid leakage. I've kind of always hated that name. It does not look like petals to me, but somebody felt like it looked like petals, I guess. You also have these little foci of leakage kind of scattered around. These are the right and left eye again. I did not do an early and a late. These are just late pictures. This patient, I have a little bit of a clinical course on them. So whenever I see these bilateral cases, and it seems systemic, I usually want to treat them systemically. And so before I do that, you got to make sure they don't have like syphilis or TB. And we've actually kind of been having an uptake in that, which is not super good. But I've been getting those coming back positive lately, and then you got to report them to the CDC, stuff like that. So this patient, we did infectious etiologies and did an inflammatory workup, and everything came back negative. They were started, I lied to you, I didn't treat them systemically. We started them on Durezol 4 times a day, and you can kind of see the subretinal fluid went away. So this little pocket here disappeared, but still had some CME in there. And that, if it's not going fast enough and they're pretty significant, we go forward pretty quickly. So they got a subtenon's Kenalog, and I think they ended up with, what I put, like 3, and it went away. A lot of these will keep coming back. And this one didn't. So something you'll notice, and I want to point out, is this person ended up developing a little ERM, which is very common with these inflammatory things. I have found that these patients who have inflammation, you treat them, they get ERMs. If they're stable, I don't touch them. If the ERM gets really bad or it keeps swelling and coming back and the ERM's growing, I will take it off. But when they're stable, if you pill this thing, they're going to have a lifetime of swelling that keeps coming back, and you're going to have to keep treating them the rest of their life. And that's painful to watch because they really don't have anything else wrong with them. It's just their inflammatory eye. You caused it because you got it to go away, it was stable, and then you went and did a membrane peel, and now it's like this, almost like an Irvine gas syndrome, only it just keeps coming back and coming back and coming back. And then, anyway, just FYI. So here's another patient. They've got a little subretinal fluid. They've got some CME in there. So we did test. We've got, interestingly enough, their optic nerve, totally dark. That's very uncommon, especially when you've got like these little petaloid type changes. The vessels look very good. And so with this patient, it didn't do anything. I had another hint though in their medical record. They were on Gilenya, which is medication. We stopped it, and that's all we had to do was stop it, and the swelling went away. I bring this one up because there are lots of new medicines, especially in the oncology world, that are coming out that seem to interact with this like swelling system in the retina where it causes swelling. On the angiogram, sometimes you have no leakage, sometimes you'll have petaloid leakage like that. But if the optic nerve is totally quiet and the vessels are totally quiet and you've got swelling like that, you got to do a little more digging. There's something else. And sometimes it's these weird medicines that they're starting to use. On a side note, there's some newer oncology medicines that also cause uveal effusions, and you get these angle closure glaucomas and these big myopic shifts. So be aware of that as well if you're getting those patients coming into your office. And the oncologists aren't always aware of it. I had to get in a fight with one recently, and I won, so the patient's eye was saved, but he was not happy with me making him stop his medicine. So here's another patient. This one doesn't have any subretinal fluid, but you can kind of see these, little cystoid spaces in there. If we do an angiogram, you do have some little aneurysms that are popping up, and they're all leaking. Almost looks like petaloid leakage, but it's in the distribution of this inferior kind of arcadish area. This patient has a vein occlusion, so we gave some anti-VEGF, it responded normally and went away. Here's another patient. This one's a little bit interesting. You may not think about a lot, but you can see there's a posterior staphyloma that kind of has nothing to do with it. And it's kind of hard to see on here, but in this kind of mid-retina, there's these little cystic spaces kind of all along the retina. And you can't see in the picture, but there are some pigment changes kind of out there, and I forgot to include the color photo, sorry, but this patient has retinitis pigmentosa with these little cystic spaces. And man, these pictures didn't show up very good. So carbonic anhydrase inhibitors will sometimes make those kind of wash away, which it did for this patient, even though you can't see the picture. So with these patients, carbonic anhydrase inhibitors, as long as they're tolerating the drop fine, they're not getting like a super red irritated eye, I just keep them on it forever. I mean, it's got supposedly some neuroprotective, and it makes those little cysts go away. Is it really doing anything? Maybe, maybe not. I mean, their vision's like 2200. Any hope that you can give these patients, I think they appreciate. So. All right, here's another patient with CME. This one, again, that broad-based vitreomacular adhesion. Sometimes you'll get vitreomacular traction causing CME. I should have included one of those, but I didn't see a patient that day with it. Kind of see that. So with this, we do an angiogram, and this looks terrible, right? He has kind of that petaloid look. His optic nerve's totally inflamed. The blood vessels are all inflamed. He's got leakage just everywhere. He's got posterior uveitis here, right? And so, let's see, I only put the right eye, or the left eye. So this was what both eyes looked like. This is another one. I'm going to kind of go through my treatment that we did with them. We did labs, infectious were negative. Autoimmune diseases were negative. I did send him to rheumatology. In the meantime, we started oral prednisone. I usually start about 60 milligrams with these patients. If they're very large, might even do like 80. But this is after having 60 milligrams for a week or two, and you can kind of see it's gone down, but it's not totally gone. So then we had it start to come back, and he's still on 60 milligrams. So that's kind of, I don't want to keep going higher. In the meantime, he's seeing rheumatology, so I went ahead and started Durezol, which is a great drop. I feel like people kind of shy away from it. It does affect the IOP a lot of times, but it did get a little bit better on the topical Durezol. But then it started getting worse. So he's on like 60 milligrams of Pred. He's on maximum topical Durezol. So I went ahead and I added a subtenon's Kenalog. And you can't see it, but it actually got worse after that. So he's pretty maxed out. Rheumatology saw him, and I don't know why, but they reordered a QuantiFERON Gold, and it came back positive this time. But they said, we don't believe the results, so they ignored it and gave him IV Solumedrol, which he doesn't have TB, so that was okay, but I had my head scratching. Why'd you order the test if you're going to ignore the results? But it got better with IV Solumedrol, but didn't totally go away. And a week later, it's starting to come back. So they sent him off to the Mayo Clinic, and the Mayo Clinic said, this looks like a genetic problem, stop all your medicines and just take dorzolamide, which I thought was interesting. And doing that, it got worse. They said, I know it's getting worse and your vision's dropping, just keep doing the dorzolamide. So he did, and it kept getting worse. Again, this is both eyes. And so finally I talked some sense into them. I said, look, even if it's genetic, this is getting worse. You did respond to steroids. Let's go ahead and put an Ozurdex pellet in. And he got the Ozurdex pellet, and it all went away. So that was good. But by the time we got to this stage, it had been quite a while. And he's got a membrane that grew there. And he does have some, you can kind of see about here to here, there's some disruption in that photoreceptor layer, so he's had some permanent vision loss now. After, I think this was at about 11 weeks, or 2.5 months is what I put on my slide, it started coming back. The Durezol started wearing off. So we did more, and he got sick and tired of it. So finally I said, look, you've got this nice membrane. You don't want any more of these injections. Let's go ahead and take the membrane off and put in a Retisert. I don't know, has anybody used Retiserts out here? No, all right. Well, you can't use them anymore anyway. So they're a great product. They work fantastic. This is him after, so he put this in a few years ago, and he's had 0 injections, 0 topical medicine. It's been good. Well, I shouldn't say 0 topical. He's had some glaucoma because of the Retisert. But he keeps his pressures good with the glaucoma folks. Now the Retiserts, also side note, I think I'm getting close to time. The manufacturers, the plant that they were using, I guess, doesn't make it as safely as they used to, so the company said they looked for other places, but nobody met their standard of care, and so they're just dropping the product. Which is unfortunate because these really work well. They're supposed to work 3 years. I've had a patient that didn't have a recurrence for like 5 or 6 years after one of their Retiserts. So they do have an inventory currently, so if you've got that patient that might need one, you can probably still get it, but for not much longer, unfortunately. All right, so here's another picture. You've got these kind of cystic spaces. It's not really subretinal fluid, although it kind of looks like it. This is an older patient. Fortunately, I don't have very many of these. I'd like to say it came from somewhere else, but it may not have. But if you look up here, there's kind of a clue. There's bubble, 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 big bubble where the cut's taken. This is subretinal PFO. Okay, so it can look like some CME or subretinal fluid, but again, look at the whole picture, get their history. Sometimes I get referrals for this stuff floating up at the top of their eye in the vitreous cavity. And I guess the doctor didn't ask if they've had Avastin 10 years ago. Silicone oil gets in the eye, it'll accumulate, and that's floating. Sometimes I get referred, and there's this stuff at the bottom of the eye. Well, what's heavier than water? PFO. Sometimes it gets under the retina. So just, kind of keep those things in mind. It's not very common, but it'll come up. So here's another patient, and you've got kind of those like schisis-like CME. This one, you've got this membrane, and you can see it's just pulling and ripping those layers of the retina off, right? You can mechanically see that happening. If you do the angiogram, so I've been burned on these sometimes from like, it's a membrane, and then they come back a month later, and well, there was a CNV there too, whoops. So I was doing an angiogram on those. And with this one, you can see there's these striations that I was talking about earlier, and that's the wrinkles in the sheet. And there's no leakage at all, no CNV, no inflammation. Oh, that's the other thing. A lot of these ERM schisis like CMEs, they'll have some kind of a vasculitis or an inflammatory thing. So also a reason I do an angiogram on it. This person doesn't have any of that. It's just the ERM. So they're pretty safe to do surgery. So we went ahead and peeled it. And I show this because if you look close enough, there's still these little cystic cavities. This ERM didn't grow overnight. And when you have these cavities in there for a long period of time, no matter what you do, sometimes you're going to get a little residual CME. This patient got to 20/20, so they were happy. I don't touch that if they're 20/20 and they're happy, especially when they have chronic cystoid-like spaces that we tried to fix. Here's another patient. You can see the ERM isn't quite as obvious, but there's these little wrinkles along the surface. There's these schisis-like CME. It's all along one layer, pretty much. You might say that's not in the same layer, but... and here's the angiogram. Again, the wrinkles in the sheet, you can kind of see those going on. There's no leakage. There's no leakage to the nerve, no vasculitis. This is also a patient you can do surgery on. They're not going to have as big of a change in their vision or benefit, but I'm pretty happy with that. I show this because sometimes those schisis splits don't all come back together again. But usually these patients are pretty happy and they don't notice that. Here's another ERM patient. I actually have the right eye or the left eye over here and the right eye there. I got this one backwards, I guess. And this is a big ERM. There is some wrinkling, but it looks more like they thickened the retina up as opposed to those wrinkles. There's no splitting. There's just a little CME in there. I probably did an FA, maybe not. So with this one, I show the surgical result because you can't see the foveal depression still like the other surgeries I showed you, but it's pretty remarkably improved. I didn't put their vision on this one, but I would assume it improved at least a couple lines. This is not going to make them 20/20. So one of my pet peeves is you get somebody sent in, they're like, they said you could peel my membrane off and I'm going to be like I was when I was 20. That doesn't happen. I'm removing a layer of your eye. I always take the ILM off. Whenever you do that, it does dim the vision a little bit, okay? And so you want to make sure you're dimming it less than you're improving the rest of the structures. That way they see some improvement. If you don't think that's going to happen, I don't operate on them, unless they have a lot of distortion. But they, you do get some pretty good results, but their vision is not 20/20.
Do you have a guideline for vision?
For vision, no, I don't. I don't have a cutoff. A lot of it, I don't know if you're here for the cataract lecture, a lot of it's personality. If the patient's expectations don't seem like they're where I want them, I won't operate on them. If they're not, if their activity of daily living isn't really being affected or they don't have distortion, I don't really operate on them. If they understand it's not going to be 20/20 vision after an ERM surgery and they understand our goal is to stabilize, then I'll operate on anybody even if they're already 20/20, okay? As long as they have that understanding. To answer your question? Yeah, okay. This is a new one. So we got some CME here. Again, as you might guess, I did an angiogram. This one we've got your nerves lighting up. You've got some petaloid leakage. The vessels, they look pretty good. I don't see a lot of leakage in there. They have a history of cataract surgery. And so we just treated this with topical drops. I didn't point this out, but they do have a membrane there, and sometimes that'll lock in the CME a little bit. But when the CME goes away with topical drops, this ERM I would be very hesitant to operate on even if it grows a little bit, because like I mentioned on a patient before, when you have any history of swelling before a retina surgery, After the retina surgery, it's going to be chronic recurrent swelling, and they're going to be on some type of a long-term drop or have an injection regimen that they don't want to deal with the rest of their life. So for this patient, I would be more hesitant and make them suffer longer if we were going to do an ERM, because that's going to happen with them. All right, here's another patient. This one's got the vitreomacular, narrow-based vitreomacular adhesion, and you say, well, maybe that's traction. It's not, but there's some CME there. Little change right there in the middle. If we do an angiogram, it's kind of obvious what they have. They've got these aneurysms. It does not respect one of the arcades. It's on both sides. They do have some blockage here with some little blot hemorrhages. This is a diabetic patient, so they have DME. Treat those with injections, which is what they got, and they respond very well. I do a lot of focal still. I do not do focal when it's right along the FAZ. I would probably laser some of these spots, maybe over here, but I wouldn't get those closer ones. Oh, I might be out of time. Am I out of time, or? Oh, something's happening. Something going on? Oh. Where's my mouse? Something I did. Well, while he's up here, I do have like 40 more slides. I know I don't have time for that. Any other questions? Go ahead.
As far as the ERM peel, you said if they're, I'm just trying to understand, the uveitis, surgical inflammation, those types of things is where you'd be hesitant to peel it.
Yeah, anytime somebody has a little swelling before a retina surgery, there's a high risk that they are going to have chronic recurrent swelling afterwards. I mean, it's usually treatable. A lot of times it's just drops, but nobody wants to be on drops the rest of their life for a year or two, but after that they start getting non-compliant and then things progress.
Does that mean, what about diabetic macular edema?
So that's a little different. I guess I should clarify that. Anything that's like an inflammatory type etiology, whether it was cataract surgery that incited it, or they just have, some people just have this low-lying inflammation, especially your smokers and things. All right, thank you. Does that answer your question?
Yes.
Yeah, okay. Let's see. Do you guys want me to keep going? 2 minutes, okay. Let's go quick. I might skip some of these. We'll go to retinal thin. Oh, so this is another thing that it's a little bit tougher. So people send in, they're like, the OCT shows thinning. So if you look up here, you've just got this diffuse thinning in the retina. They're like, what's going on? So this patient, quickly, I'll just jump to it. They were my, this is my plaque window toxicity patient. So the photoreceptors here look great. To either side of that, they're gone. You've got this like flying saucer kind of look. Somebody coined that. The FAF is great on these patients. It's super obvious. I'm going to skip some of the background. It was kind of interesting, but here's another one where we've got some thinning that's diffuse. If you look at the patient, all the layers are there. They look great. They're a -7. Myopic patients, as we know, you get those like thinning of the peripheral retina. Well, the whole retina actually thins. It's like a balloon. You blow it up big, the wall's thin. These usually don't progress unless they have pathologic myopia. Here's some thinning here. The hint is it's the inner layers that are thinned out. This was a patient who actually had endophthalmitis previously from a vein occlusion. They got injections. But here's their angiogram with the MAs when they were leaking. This is a patient who has some sectoral thinning up here. If we jump over the optic nerve, which, that's interesting. There we go. If you look at the optic nerve, you've got this area here that has some pallor. The rest of the nerve looks fine. This person had a non-arteritic anterior ischemic optic neuropathy. It's kind of a mouthful. If we go to this patient, they have very similar. You've got this upper, quadrant area here. This was my patient who had the Wegener's granulomatosis with the occlusive vascular disease. This was a 10-year-old. We do not have any information here really for normal because they're under 18. But you can see total diffuse thinning. If we look at their picture I took after I treated them, unfortunately, our camera was broken that day. Otherwise, I'd have some really cool pictures. Left eye looks normal. The right's got these pigment clumps. Vessels look dead. The retina's totally thinned out. This spot was not there when I first saw him. What was there was a worm. It was crawling around in his retina. It's the weirdest thing I've ever seen. So he had Deucin. You just laser that, and the worm just it explodes and evaporates. It's kind of neat to see. We had a person in my community a number of years ago. They were very heavy on the focal laser. So this is some laser damage from that. And that causes obviously retinal thinning. This patient, your cheat sheets up here, you've got this is like the poor man's fundus autofluorescence, right? They've got some geographic atrophy there. So that causes retinal thinning. These also, fundus autofluorescence is great for these patients and tracking it over time. We don't have time, but there's some new drugs I was going to mention here. But this patient, let's see, what do we got? With chronic systemic diseases, your retina thins. So like your diabetes, your hypertension, any kind of inflammatory thing, that just happens over time. And so that was going to be my example of that. Here's the diabetic. Let's skip through that. Myopic patients, this one's more obvious than the last one because there's a posterior staphyloma there. Those posterior staphylomas stretching the retina out. Here is a patient who has some focal thinning. Right here, you can see this is a young patient as well. They were almost 18, but not quite. This patient has an inherited retinal dystrophy, and so centrally you can see pretty good, and then centrally that outer retina is disrupted, so their vision's pretty bad, but they have good peripheral vision. And I think they're kicking me off the stage. So, any questions? Okay, thank you very much for. Go ahead.
So do you have anything that you tell your patients that don't want to get injected? So they have edema.
Yes, I do. So briefly, there's always more than one way to skin a cat. The injections are usually the best. I tell them, so depending on the disease, right? With macular degeneration, for instance, I go through the 3 treatment options. You can laser it. We're going to burn it. It's going to have a blind spot, and the blind spot ups to triples in size over a few years. You can get photodynamic therapy. When the FDA approved that, it showed people who had it done lost less vision than people who didn't. Or you can get the shots. When that got FDA approved, most people gained visions. So that's the difference between them, but I'm happy to do whatever you want to do.
And then do you tell them, look, if you don't do anything for this in the next 6 months, you're going to lose
So I don't usually give them a time frame, but yes, I say your retina is a piece of central nerve tissue. It is brain tissue. If you know somebody who's had a stroke, they lost their arm, it never comes back. The longer the fluid's in there and the more it grows, the more permanent damage will take place. And some patients don't do anything, but I respect that as long as you can document that they understood that and you explained it. Okay. All right. Thank you very much for your time.
Thank you very much, Dr. Davis. That was a wonderful lecture. I'd like to introduce a good friend of mine, Dr. Aditi Gupta. She and I did fellowship together in Boston a few years back now, and she is currently working in the California VA system. Please welcome Dr. Aditi Gupta.